Thank you all for attending this seminar. It gives me great pleasure to introduce Associate Professor Louise Coleman. Louise is the Director of the ALERT program, the Australian Lymphoedema Education Research and Treatment Centre in the Faculty of Medicine, Health and Sciences, who is also the head of the Health Sciences. And really, with her and her colleagues, and also got the pleasure of having the inaugural Director of ALERT, Professor John Boyages, with us today. Really, ALERT personifies the purpose and mission of Macquarie University Health Enterprise, which is Heal, Learn, Discover, integrating those three important elements of academia and health practice. And so it's a great pleasure to always explaining the work to a relatively lay audience. So I know there'll be a mixture of experts and non-experts, but that's the brief, to have a seminar to be understandable by people who aren't in the field. So many thanks, Louise.
Thank you very much, Patrick, and good afternoon, everybody, and welcome to this session I've titled it Keeping Alert, Innovative Assessment and Management of Lymphoedema. So for the next 40 minutes or so, you need to be alert, stay alert, because we're going to talk all things lymphedema. I would like to acknowledge the traditional custodians of the lands we're on. Macquarie University is a beautiful campus, and this campus is known as the Wallumattagal campus. And I'd like to pay my respects to the Darug people, who were the first people on this land, and pay my respects to elders past and present, and to any Indigenous guests here with us today. I'd also like to say Happy Lymphedema Awareness Month. I asked the organisers of this seminar series, could I be scheduled for March, because March is the International Month for Lymphedema Awareness. And those of you who may be linked with our program or on social media may have seen lots of things that are blue at the moment, because blue is the lymphedema colour. And we're very grateful to Macquarie University, who have agreed for the second year in a row now to light up the Student Connect building, which is in the main central part of our campus here. You've got to come here of an evening to see it. But Robin, my colleague, came in to take photos of the building, and it's lit up blue for the whole of March. So if you're working late or visiting late, walk through the beautiful campus and take a photo, post it to raise awareness for lymphedema. So what I'm going to be doing in this session, and I'm aware we've got a really diverse audience, which is fantastic, and appreciate everyone for giving up their time to be here today. We are also recording the session, and so to those who might be watching online as well, welcome and thank you for watching. We're going to give a brief overview of what our ALERT Centre is, what is the work that we do. Then I'm going to talk about some of the science that we're doing in our program, and hopefully this may be relevant to some of you, and hopefully share some of my visions of where we want to be. I'm going to talk about what I call the prospective surveillance and early intervention model of care. A lot of the work in this model of care is happening in the area of breast cancer, but it's my real vision, and I've said this publicly many times, it's my vision that all individuals who are diagnosed with cancer and are at risk of lymphedema have access to this model of care, which is prospective surveillance, so a screening for lymphedema, so we pick it up in the most earliest stages, so we can then implement early intervention to try to prevent progression to this long-term chronic condition that we see in our clinic. I'd also then like to talk and share with you some of the innovations that we're doing in our program here at Macquarie University, both conservatively and surgically. So it's a bit of an overview, but with some of our science, some of you have heard me talk before, so I have to think every time we need to do something a bit different. For those of you who aren't aware of our program, we are known as the ALERT program, which does stand for the Australian Lymphedema Education, Research and Treatment Program. So it is a long name, so that's why we are known as ALERT. So stay alert for this talk. We are a multidisciplinary, and I would say nationally and internationally recognised program. And the three names in our program are the three arms of how our program works. And like Patrick alluded to, we very much are immersed in the Heal, Learn, Discover of our faculty and of our health science academic centre. Education, we're providing education to health professionals who wish to specialise and become accredited lymphedema therapists across the country and New Zealand. We also are involved in educating our own NQ students here. We teach medical students, physiotherapy students, Bachelor of Clinical Science students, as well as students wanting to do higher degree research, so a master's or a PhD. If anyone's interested, talk to us afterwards. We're involved in research, and our research is translational clinical research. So we've got a diverse team, and you'll see some of our members of our team here wearing the blue shirts, so they stand out. And all of the work that I'm sharing today is very much about how a team is integrated and how a team works together to deliver the outcomes that we're doing. No one individual can do this. I just have the privilege of leading this team that delivers these services across these three areas. Then we have our treatment arm of our program. We have a treatment clinic down in 2 Technology Place where we do both conservative and surgical management of lymphedema, and we have very much a multidisciplinary approach. And our mission underpins the work we do. Our mission is about delivering high standard, personalised clinical care, evidence-based education and innovative translational research. And there's no end to the research that we can do in this space because there's very little evidence that is building, but we've got a long way to go if we compare it to some other medical condition. This is our team, and as I say, I want to acknowledge the team. There's over 30 of us in our team, medical practitioners, rehabilitation specialists, plastic surgeons, imaging specialists. We're fortunate to have 7 lymphedema therapists, half of them are occupational therapists, half of them are physiotherapists. We have an amazing team of researchers, all from a health background. And then we have an amazing support team of clinical, education, administration support that we need to deliver on what we do. And the final row there are our amazing honorary professors that we collaborate with. John Voyage is my colleague who I met in 1996. I was 5 then, just so you know. Met in 1996 when John was the director of the Breast Cancer Institute at Westmead Hospital. I was setting up a lymphedema clinic at Westmead Hospital in the OT department, and we started communicating and talking lymphedema. And I like to think that everything he knows about lymphedema comes from me, but John came to Macquarie and had the insight, the innovation to develop this multidisciplinary program. And I have big shoes to follow in what John started and created. But collaborators also who are honorary professors from Sweden, from India, and our own Lee Ward from Queensland. So I feel very privileged to be working with this team of people and really want to acknowledge them. And that's why they're wearing the blue T-shirt. So you can say thank you for the work that they're doing. Also need to recognise that we've been identified as a Learn Centre of Excellence. This is an international recognition by what I call the peak body of lymphedema or lymphatic diseases across the world. They're based in the United States. And we were one of the first 6 centres that were identified as a Learn Centre of Excellence. And we're really proud to hold that status. And we're quite involved with Learn, supporting them and supporting their mission to increase awareness of lymphedema. For those who may be unaware of what this condition is, and I'm not sure that this is relevant for this audience, but lymphedema is a condition. Edema means swelling. Lymphedema means swelling caused by a blockage or a disruption to the lymphatic system. We know that a number of our patients, a large proportion, have lymphedema secondary to cancer treatment. And you'll see by the photos here, these are real patients after breast cancer, melanoma, primary lymphedema and head and neck cancers. So this is a sort of a visual of what the condition is that we're looking at. And as you can see from these photos, and some of you have lived experience as well yourself, this is often after a cancer diagnosis, the ongoing daily reminder that someone's had a cancer diagnosis, that they can be cured from their cancer, they can be moved back on and finished all of their intensive treatment. But if they develop lymphedema, this is this chronic daily reminder that they have to do some self-management in order to keep the condition under control. So it not only affects people physically, so being able to do day-to-day activities, they've got a heavy, swollen, aching arm or leg, It affects them functionally. It affects them also psychologically, body image issues. Can they wear clothes? If I had lymphedema in my arm in a significant way, I wouldn't be able to wear the jacket that I'm wearing. I'd have to think about, what am I wearing? And also financially, because lymphedema is an expensive treatment, and it's very inequitable across the country, and we need to be looking at how can we pick this up in the earliest stages as possible, because the costs of managing early stage lymphedema, which we term subclinical lymphedema, is much more effective than the long-term chronic lymphedema like you see in these pictures. So this is our team. We are very fortunate that we have a multidisciplinary team meeting, like a case conference meeting every second Friday morning. We meet down in One Wally's Walk, which is our medical health building, and we discuss patients. We have about 15 patients coming into our surgical clinic on a Friday, and we have the imaging specialist, Professor Kevin Hoshon, sharing the MRI results, lymphoscintigraphy results. And as a team, we go through their medical, their social, their lymphedema history. Many of those 15 patients coming in each week to that clinic are coming from interstate or New Zealand to access treatment with us. So we feel pretty privileged that these people are choosing to come to us here. And I really award the team for just the complexity of patients that are now being referred to us, because we're being known as being able to manage the complex, more severe cases that perhaps aren't being managed well in their local community. We've also recently set up our own Alert Consumer Advisory Committee, and what we're about is co-designing and working with consumers in everything we do. Very fortunate to have Sharon Hearn with us today. Sharon down the front is going to be part of our Q&A session. We go back a really long way when you went through breast cancer treatment. Sharon has developed lymphedema and been through our clinic, but is a real advocate for best practice management, but also about living your life. And we learn so much from our consumers, and it's really good that we've got some consumers here today. We've got a broad range of themes that we're involved in our research arm of our project, of our program. And you can see here, there's so many unmet needs when we talk about lymphedema. Our problem sometimes is that we go so broad. So today I'm going to talk most of the research about breast cancer-related lymphedema, just so we stay a little bit focused. So I want to share my observations and reflections. And for those who don't know me, I'm an occupational therapist, a lymphedema therapist at heart. I'm a clinician trained and worked in this area for over 30 years. I did start very young. But I like to look at this photo here, and I think we're in a really unique position in Australia in that we can actually observe what's happening internationally. We can look at what's happening in the UK, in Europe, in Asia, and in the United States, and we can cherry pick the good from what's happening, and then we can make our own. We have lots of collaborators internationally. We have regular monthly meetings with our colleagues in Boston from the Massachusetts General Hospital and the Boston Lymphatic Centre. I was on a call last week with Vanderbilt University and last night with Germany. So we're really now starting to have these colleagues that we're learning from them, and they're also learning from us. And we welcome and host people to our clinic to see how this multidisciplinary clinic works in action. So I sort of think of us looking at what's taking the best of everything. But when we move now more into breast cancer-related lymphedema, over the last 30 years, breast cancer-related lymphedema has changed significantly. However, there is still lots of myths and misinformation out there about this condition. Most of the research in the past has happened in managing the breast cancer, which is really important. We want people to be cured from their breast cancer, and John certainly had a part in that as a radiation oncologist. But what we've seen over the last 10, 15, 20 years, breast cancer medical management has changed significantly. When I first started as a little OT at RPA Hospital, women were in hospital for 2 weeks when they had their surgery. And I was going in and educating them about lymphedema as part of their inpatient stay. That doesn't happen now. Women are in hospital for day-only procedures or overnight if they're lucky, and then they're home. So the surgery might be the same or refined and improved to what it's been, but the way we manage breast cancer has changed. Likewise, chemotherapy regimes have changed. Women are now having a lot more of what we call neoadjuvant chemotherapy, so having chemotherapy to shrink the tumour before we then go and do less invasive surgery. Radiation's changed. People used to be having radiotherapy over 5 or 6 weeks. Now we're doing more regional node radiation. The timing of radiation is now often shorter, 3 weeks, even 1 week, depending on where they're accessing their treatment. So we've got to consider these as the medical management's changed. This is all going to impact lymphedema. You know, there's questions. Do we escalate treatment in one area, do more radiation treatment and less surgery? What's going to be the ramifications for lymphedema? You know, we used to do complete axillary dissections, take all of the lymph nodes out under the axilla for individuals, and it was a 1 in 5 chance of getting lymphedema. So it was very common, and people, as soon as you told someone you were having breast cancer surgery, they said, be careful of your arm, watch out for lymphedema. We've changed now, and the challenge is that some of the social media and some of the information out there available for consumers is still saying things that happened years ago that people aren't up to date with the medical management and how it's changed. There's advances in hormone therapy, there's advances in targeted or immunotherapy. So these are all having an indirect effect on how we assess and manage lymphedema. Likewise, when we talk about lymphedema, then there's a whole area to talk about, well, how do we assess lymphedema? How do we measure lymphedema? There's actually probably not one gold standard tool for how we assess and define lymphedema. And these are some of the technologies that are out there to assess and measure lymphedema. But I have been told that, you know, we've got to understand what each tool is measuring and how we interpret it. So I sort of say to people that it's like a big black box. Unless you know how to interpret these tools, and we have most of these fancy tools in our clinic, whereas people in a rural or remote setting may not have access to that, and they have just access to a good old tape measure. So we need to educate people in what each tool is measuring and how we interpret the results to then help us guide our management. If we can't get it right in assessment, then how do we manage lymphedema if we can't have measurements that we can see trends over time? So I'd like to introduce this model of care, prospective surveillance and early intervention. So what this model of care is, and I said it earlier, that all individuals at risk of lymphedema have access to a screening program. We have national breast cancer screening programs. My vision is we have national screening programs for lymphedema in all healthcare settings. I can tell you where this model is working well. I can tell you where it's not working well. And that's not equitable for patients at risk of this condition. We want it that if you're diagnosed with cancer, you should have this model of care. But there's challenges in implementing this model of care across different health settings. We really need to be working in a collaborative, multidisciplinary team setting. We say to our students, one little OT or one little physio can't take on being able to implement this model of care across the whole healthcare setting. We need to work in with medical practitioners. We need people like John and other medical specialists to take charge and say this is important because it's a survivorship issue after cancer. And what we also need, if we're implementing this model of care, we need to have a clinical protocol so that we know what to do when someone triggers early intervention. And we can't screen everybody and say, well, 10, 20 people have triggered early intervention this week, but sorry, we can't fit you into the lymphedema therapist for a month's time. We need to be able to implement it straight away. So can you see how this model is quite complex in reality, and that's why we haven't got it implemented everywhere. This model of care is aiming to detect what we call subclinical lymphedema or stage 0 lymphedema, or early stage 1 lymphedema when the symptoms are very minimal. And the goal is that we know that early intervention is much more easier to manage for an individual than someone who gets chronic, full-blown clinical lymphedema, but then it's not reversible. Likewise, we know that early intervention, there's been good evidence to show that it prevents progression to chronic lymphedema. So are you all on board? Can you see that this model of care is really important? So just a bit of a snapshot of how this would work for someone diagnosed with breast cancer. And we start with breast cancer. I'd love this across all cancer groups. But we say now an individual should have access to a baseline assessment at the time of their cancer diagnosis. We used to say a pre-surgical baseline because surgery was usually the first point of call, but now we say pre-treatment to try to access those women who are going to have neoadjuvant chemotherapy. We want to get a baseline before any intervention starts. Then we want to screen them on a regular basis, and I'll talk about the protocol afterwards, and we want to give them education. But we always say to our students that at the time of someone's diagnosed with lymphedema, with breast cancer, lymphedema is not the priority there, and I totally understand that. You know, if someone's diagnosed with cancer, they want to know, am I going to survive or am I going to die? Am I going to see my child go to school or my daughter get married or go to university? So we've got to be really realistic in a drip filtering of education so that it's the person comes along with the journey to understand about lymphedema in a timely way. And we know that people only probably take in about 20% of what they hear from a medical practitioner or a health professional when they're first diagnosed with cancer. So we need to have it slow and repetitive information. Then we do ongoing education, and we need to be involved in the rehabilitation, helping and supporting women with their musculoskeletal, helping them get their shoulder range of movement, helping them manage their scars, helping them manage their fatigue while they're going through their chemotherapy. All of that, little trigger points, is the screening program. And then when someone triggers early intervention, then we implement early intervention with a compression garment, and I'll show a photo of that in a minute. Skincare, exercise, and education is ongoing through the process. And hopefully when that early intervention works, then they go back into the normal screening because they've got this subclinical lymphedema. So why should we adopt this model of care? Not because just I tell you that. There's significant clinical and governance evidence internationally that supports this model of care. So these are key peak bodies in the cancer and the lymphedema worlds internationally that have key position statements highlighting the need to implement a screening program. Likewise, there's significant clinical evidence backdated from the early 2000s. Dr. Robin Box is an Australian physiotherapist, did her PhD in this area, and then we've built on this over time with some prospective studies, some retrospective, and some randomised controlled trials. We had the privilege, our side, being involved in what we call the PREVENT study, which had 1,200 women, and I'm going to share some of the results of that study. But you can see it's not just one or two studies happening. The clinical evidence very much supports this model of care, and it's a bit of a no-brainer. And when I see patients even now, they say to me, if someone hasn't had access to this model of care in the early days, they have a problem and then they get referred. And once I've helped sort the problem out, I talk to them and say, well, this is what we propose as the best management for you. They feel really ripped off when they hadn't been offered it from the start. So we need to be advocating for our consumers, and even all of you. We're all going to have someone who's diagnosed with cancer in our lives. If lymphedema is a risk factor for them, we need to get them onto a screening program. More research that some of our staff have been involved in more recently as well. And then I'm going to just share a little bit about the PREVENT study. So this is a study that gave me a few grey hairs over about 5 years. We were fortunate to be invited to be the Australian site for this study. This study included 1,200 women from across America and Australia, but we were the only site in Australia at Macquarie University. We recruited 450 of the 1,200 women here from our site, and some of my team are here who were part of that study. We invited women to participate from Westmead Public Hospital, Macquarie University Hospital, the Sydney Adventist Hospital and North West Hospital. And I had a team, the study was funded, and we had a team of people who were out recruiting women, inviting them to participate. We had no problems in recruiting the women because we had doctors who we'd met and we'd worked with and were very on board with this model of care. And we actually found that we were monitoring these women at 3 monthly intervals for 3 years while they were going through their initial treatment and beyond. And this study was looking at some primary aims of the study was to determine whether subclinical detection of extracellular fluid being measured by bioimpedance spectroscopy, and I'll tell you a little bit about what that is in a minute, and subsequent early intervention reduces the rate of progression to clinical lymphedema. And we were comparing that to the standard method of measurement using a tape measure. We also looked at some secondary aims of other factors that were risk factors for developing lymphedema as well. But if you could imagine, with 1,200 women, we had a lot of data. We published 10 or more papers since that, and we're still even now looking at some of this data. I don't know if you recognise that's you, Sharon. So this is Sharon standing on the bioimpedance device. The bioimpedance measures extracellular fluid, and it compares if it's arm lymphedema, the at-risk arm compared to the unaffected arm. And we get a reading known as an LDEX or lymphedema index. There's a normal range for where this fluid should be. So ideally we get the baseline, so then we can start monitoring and seeing trends over time. We know through the research that's been published that a change of 6.5 LDEX points from baseline is the trigger for early intervention or subclinical lymphedema. So that was our criteria for the study. We would monitor these women and then we would intervene when they triggered a 6.5 change if they were in the bioimpedance group. It was a randomised controlled trial, so women were randomly assigned to tape measure or bioimpedance. The other group were measured with the tape measure, a little bit trickier. We had to do lots of training of our staff at 10 centimetre intervals. The normal indicator for clinical lymphedema is a change of 10%, means clinical lymphedema. So if we were looking at subclinical lymphedema in this study, we were looking at a volume change of greater than 5 and less than 10% volume difference. We had it all programmed in our software, so we didn't have to determine that with our own calculator. And now I just share what the results of the study were, after I tell you what the intervention was. So the intervention was when these women triggered, whether it was via tape measure or the bioimpedance device, they were measured and fitted with a compression sleeve and gauntlet. 20 to 30 millimetres of compression, and they were given 2 sets of these garments so that they could have one on during the day, wash it, and then have one for the next day. And these garments were supplied by Medi, one of the garment providers. The women were instructed to wear these garments for 12 hours a day for 28 days or 4 weeks of intervention, and then they came back to be remeasured to see what the outcome was from that. The results of the study, and just some high-level results, there's lots of publications we could go through, but basically it showed that there was significantly lower progression to chronic lymphedema with the bioimpedance group compared to the tape measure, which was really interesting for us. You know, we sort of had our hypothesis of what we thought should happen, and this was really a positive outcome for us because it's much more time effective to get someone to stand on the device to do this bioimpedance measure than to sit in a clinic and try to take the tape measure and get the intra-rater reliability of doing that tape measure. So this was a good news story. And I have to say that one of the sponsors for the study was ImpediMed. I've got a couple of colleagues from ImpediMed here today. ImpediMed is an Australian company and they've been a long-term collaborator with our alert centre. So thank you. Also, what was interesting was the triggering time for these women. So we were monitoring them at 3 monthly intervals over 3 years, which is a big investment. Some of the women were actually sad when they finished the 3 years because they felt really empowered that they were being monitored closely so we could look at this condition. But, you know, 50%, 52% developed subclinical lymphedema in the first 9 months after their diagnosis. but we were still getting women up to 3 years triggering for subclinical lymphedema. So when we're now talking about implementing this model of care and getting it standard of care out there, we need to be recognising that we're looking at a 2 to 3 year monitoring period in order to get those cases that are developing early in subclinical. There was also a project happening that had some Commonwealth Government funding with New South Wales Health. New South Wales Health got this funding, it was for lymphedema, and decided to put it into an early intervention program. So they put devices and trained therapists to become lymphedema therapists across 13 local health districts. They've got over 6,000 patients involved in this project at the moment, but they had the New South Wales Health cost and health economics team do some analysis. And what they found was, for the benefits of this early intervention, for every $1 that was invested in early intervention in this model of care, they were actually saving $8 of treatment for treating someone with chronic lymphedema. And within New South Wales Health, there are huge waiting lists for lymphedema treatment, in some cases 4 years waiting for lymphedema care. So if we can look at a health economics benefit from implementing this model of care, I think the politicians and government would be looking at it favourably. So just what are some of these considerations if we want to implement this model of care that came out of our PREVENT study? And interestingly, and this is, there's lots of papers out there looking at what are the risk factors for lymphedema. The top 3 risk factors are pretty common and standard in the literature. Someone who has an axillary lymph node dissection, so all of the lymph nodes removed for their armpit, they're very much in the high risk group for developing lymphedema. Likewise, if someone has regional node radiation, so radiation directly to those nodes, they're also at higher risk. And there's evidence from our study showing that those women who had the taxane family of chemotherapy drugs were also at higher risk of developing lymphedema. What we also found from the PREVENT study was that women who had episodes of cellulitis during their monitoring period, over that period, they were at a higher risk of developing lymphedema. Likewise, those who started the study with a BMI greater than 30. And interestingly for us was those in a rural area. We probably didn't have that many women at our sites come from a rural location, but the state certainly did. And it was interesting to think about that, because if patients are going back home to their rural regional area and perhaps not having access to as much monitoring from their large centre, perhaps that could be a reason why we've missed the boat and missed the early intervention. So this slide, excuse me. John and I are visual people. John was the lead author on this paper, but what we developed was a screening model, because what I am very passionate about is that we don't have the resources to be able to give every single woman who's diagnosed with breast cancer the same amount of monitoring that across the board. And we really want to look at risk stratifying women. So if you've had one sentinel lymph node removed and a little bit of radiotherapy and you're back at work in 6 weeks' time, you're at a very different risk of developing lymphedema to someone who's had an axillary dissection, regional node radiation and the full chemotherapy regime. So we need to be targeting our education and our monitoring according to this. So John liked the traffic light colour. So green is those who are at lower risk of developing lymphedema, orange is intermediate, and red is the higher risk. And this has been a really useful tool in educating our health professionals in going in, working in their multidisciplinary teams to understand, you know, what your level of risk is and how much education do you need. So just the last 2 minutes of my presentation, just want to give you a couple of highlights of what some of the innovations we're doing in our clinic that you may not be able to access in other clinics around the country. So we're using indocyanine green lymphography. This has changed our world of looking at lymphatics. This is our Associate Professor Hiroswamy. He's a plastic surgeon trained and spent his career for the last over 20 years in lymphatic anatomy research. He came to our program, John brought him on, and he'd done work using this imaging technique. Basically, we inject a dye into the base of the hand, or whichever the swelling region is, and we watch in real time with an infrared camera in the dark and a screen there so that the patient can see what is happening to the superficial lymphatic system. It's absolutely fascinating because in the past, we were just going blind, treating this condition that we thought we understood. And I've been in the clinic, and if I do the massage technique under the camera that I was trained in doing a long time ago, nothing happens to the lymph vessel and to the fluid under the skin. What we've learned is, and I've got a little thing here, if I can get it working, a little video. Yes. So you can see here that the cloudiness is what we call dermal backflow. So this is congestion in the lymphatic system where the system's not working properly. And what we find is that we now need to do a much firmer, slower massage technique to be able to direct the fluid where we're wanting it to go. So how I used to do it, we used to say pat like a cat, a very gentle, soft effleurage technique. It's not actually doing anything. And that's been a real game changer for us in how we engage patients. When you see patients and they can see what's happening under the skin, they get really empowered and they want to try to do more and more involved in their self-management. So what we've found from our research is that we have what we call original and compensatory drainage regions of where the fluid is going. So if someone's had an axillary dissection, I was trained, well, we don't massage there because they've got no lymph nodes, so let's massage anywhere else. We used to drain across to the opposite side. I was trained to drain down for the inguinal region so we can get this fluid moving away from where they had their surgery. That's thrown out the window by our research. So what we've actually found, and this is a little bit of a busy slide, but I'll explain it. So down on the left side here, the MD Anderson stage of lymphedema. 1 is early stage of lymphedema to 4 is more severe. So we get progression of lymphedema as we go down. As we go across here, we've got the 5 drainage regions that I just mentioned on the slide. And this is a study with over 400 arms. Most of these were unilateral, so it's a significant number of patients. We've got more now in our alert data bank. But what you can see is that the ipsilateral axilla, so where they've had their lymph nodes removed, look at these patients who are draining to that area that in the past we completely avoided. Okay, so this is the original drainage area. And what we're finding is the earlier stage of lymphedema, 95% of those women are draining to those original drainage regions. As lymphedema progresses, we actually see some of the other drainage regions being used. But the interesting one, in all of our research of over 400 patients, we haven't seen one person drain down to the ipsilateral inguinal region. And so when we've been invited to speak in Boston and at various international conferences, therapists look at us like, that's not right, we drain down in this area. But we've got some data to show that, out of all of these patients, none of them are draining down here. So now we target our self-management to the areas that, and we can personalise their treatment. Been a real game changer for it. And now we're starting to look at more outcomes of what we're recommending and if can we personalise a treatment for an individual to get more engagement with the individual woman. So this is just a summary of that last slide, but you can see the original drainage regions that happen for us if we haven't had breast cancer-related lymphedema. We're draining to those original regions, and those other compensatory drainage are really only used in very advanced cases of lymphedema. So this impacts how we manage lymphedema conservatively. It impacts how we teach our patients to do their own self-massage. And It impacts how we measure and fit someone for a compression garment, because if we understand where their drainage is happening, then that can help in our decision making of what type and style and fabric of garment that they can wear. Exercise and skincare are always important in lymphedema. We need to reduce risks of infection, and we need to move so we can help pump the lymphatic system. And education goes across all stages. So these are just some of the treatments that we do conservatively. I think that's your arm as well, Sharon, in bandages. If we can avoid someone needing to be in bandages 24 hours a day for 4 to 6 weeks to be able to reduce the volume by early intervention, again, it's a bit of a no-brainer. Exercise and different compression garments are key components of this treatment. And just finishing, we can't not think about surgical options for lymphedema. I used to be a total skeptic on surgery for lymphedema, and now I'm a total convert for the carefully selected individuals who are keen and committed and can afford a surgical option for lymphedema. We have 2 amazing plastic surgeons that are both trained internationally to be able to bring the latest techniques for surgery. For early stage lymphedema, we use microsurgery techniques, so lymph node transfer and lymphovenous anastomosis techniques, and we can talk more about those if people are interested. And for advanced lymphedema, we use liposuction surgery. And I just want my last slide before I hand over is just this patient, and I know I've been talking breast cancer, but this is our patient who's very keen for us to share her story. So this is Shan. Shan lives in the far north Queensland, and her leg in the top left slide is 12.5 litres bigger than her other leg after having gynecological cancer, going through surgery and chemotherapy. She used to fly to Brisbane to have an annual treatment of intensive bandaging, but in the climate she was living in far north Queensland, she basically gave up on conservative management. Her leg progressively got bigger and bigger, as I say, to 12.5 litres. She can put on weight because she couldn't move, carrying around this extra weight. Think about putting 6 2-litre bottles of juice strapped to your leg and think about how that might impact. She couldn't wear normal shoes. She couldn't wear normal clothes. She was a mum in her 40s when she came to us with 6 children. She was a primary school teacher, and she couldn't get down on the ground or on the small chairs in her year 1 class to teach her children. So she really became more of a recluse. She found out about our program on a blog site that directed her to Sydney and to Macquarie University. So she came to us. She was assessed by our multidisciplinary team and assessed to be eligible for liposuction surgery. At that time, she had difficulty getting up the 8 steps out of the front of the clinic building, and she didn't have private health insurance. So she had to go back to Queensland knowing that there was an option for treatment. She joined a private health fund, waited the 12-month waiting period, and then she came back and had liposuction surgery with our team. We did 2 weeks of intensive bandaging to remove 2 litres of fluid out of her leg, and then we removed 10.5 litres of fatty adipose tissue. And this is Shan now. You can see her here with a big smile. It's the same person. She tells me that I have to tell you that she's wearing skinny jeans. They're just not normal jeans. And she's got boots on. She couldn't do that before. She's wearing 70 millimetres of mercury of compression, high dose of compression underneath those stockings. We haven't cured her lymphedema. And I used to think, why would someone want to go through surgery for lymphedema if they've still got to wear these intensive hot stockings? But for her, it changed her life because she can now wear normal clothes. She lost 50 kilos in weight. And the middle photo there is Professor Håkan Brorson. And Håkan is the guru and the developer of the liposuction surgery for lymphedema technique. Our team have been over to Sweden 3 times to learn the technique. And that's Håkan there because we invited him to come over to help us with Shan's surgery because at the time it was the biggest surgery that we had done. And so Håkan is holding there the badge and the medal from Shan when she ran her first marathon. She's subsequently run about 5 more marathons since then. And when she comes down to our campus from Queensland for her review with our team, She just does a quick 7K run of a morning before she comes in to see our team. So she's a real success story. Surgery is not for everyone, but for someone like this, she says we've changed her life completely. And the top photo there, her dressed in the blue, 3 months after her liposuction surgery, she climbed to the top of the Sydney Harbour Bridge, 1,387 steps. Remember I said she could barely climb the 8 steps out of the front of the building. So liposuction, there is a place for it for carefully selected individuals, and she's a real good news story for us. So the take-home messages from today, I hope that you can see the benefits from the science and the literature and our work, that prospective surveillance and early intervention model of care across cancer for those at risk of lymphedema needs to be standard of care. And that's some of our implementation work that we're now starting to work with. We need to translate our results into clinical care, and we also have a responsibility to also translate it to educate our health professionals and consumers to hear what is the latest research. We really strive to work within an evidence-based, person-centred model of care. Our patients are key to help guide us, help us work to go to the next steps, to find answers. And our alert mission is about improving lives. And I hope I've been able to share that we've done that today. So I said the last slide, there's one other. I just need to give a promotion of our education program, and I'm very grateful to our faculty and Professor Kathleen, who's really motivated us to develop our education, that our education is now formalised through Macquarie University. Our students can come and become accredited lymphedema therapists, and we've been doing that since 2017. But from this year, our students can now work towards getting a postgraduate certificate in lymphedema management. And it's the first of its kind. We're the only course and training provider in Australia and New Zealand in the Southern Hemisphere, connected and under the auspices of a university. And we're really proud that our specialist clinicians can work towards getting this degree, and we've got a number of students wanting to be in that first cohort later this year. And without further ado, today is a really special day for me, and I invited John to come. John has written this amazing book. You may have been seeing it on social media recently, Lymphedema Taking Control. Now, John is a breast cancer radiation specialist. He's highly renowned internationally for the work he does in breast cancer, but he is also the most person-centred medical practitioner I know. And he's supported me and supported our program for a long time. And so I'm really proud and privileged that John, we said, let's launch this Lymphedema Awareness Month. Let's launch it in front of people where lymphedema is hopefully really leading the way in Australia. So I know, John, you want to say a couple of words, and then we can have a bit of a Q&A, or you don't want to say anything? Unlike you not saying anything.
Thank you, Louise. She's amazing, isn't she? Let's give her a round of applause. I just want to correct something Louise said. She started in 86. My first paper on lymphedema was 1983. And were you still in high school? But I must admit, Louise really, her passion is infectious. And she used to come into my office when I was at Westmead and convince me to keep funding the lymphedema program. You know, we funded other programs, nutrition and physio and so on, but lymphedema was her passion. Her fingerprints all over this book. She read it back to front several times and added corrections and queried things and added, gave me images. But it's her passion which has translated to me, and I was so pleased in 2012 or something when she accepted my invitation to join me here. And really, without Louise, lymphedema doesn't exist in Australia, and where she's got it to. We need to go further. We need to convince ImpediMed to help us get Medicare item numbers. We need women to have better access to screening through drivers like Medicare, and we need better reimbursements for garments. But Louise, thank you for launching my book. It's taken 3 years, and it's been reviewed by some of the best experts in the world, and I'm very grateful for those experts, largely through our connections here at Macquarie, to have read the book. Thank you, Louise, and
Thanks, John. Okay.